Hello everyone, welcome to the PW Method. I'm Dr. Patil and we are continuing our series on the Harrisons, and here we will be taking up one more important topic, which is syncope, or in other words you can also pronounce it as syncope. Syncope or syncope, that is the topic for today. Well, what is important for us to understand from the topic, we need to understand the meaning of syncope and how is it different from any other patient who loses consciousness, because traditionally when we say syncope, the first thing that comes to our mind is someone lost consciousness, right? But there are plenty of reasons for someone to lose consciousness. We lose consciousness in patients with seizures. Consciousness can be lost in various other conditions. So how is it different from any other case of loss of consciousness? That's what we will be studying today. Okay, so we will begin by first defining what is syncope or syncope. Pay attention to the definition, because the essence of today's discussion is there in the definition itself. The definition goes like this: transient. So when I say transient, what does that mean? It means that the loss of consciousness that we're going to talk about is going to be short-lived, right? It is not a permanent loss of consciousness, or it's not a long-standing loss of consciousness. Recovery hone wali hai. Recovery is there, right? So transient, self-limited loss of consciousness. Transient, self-limited loss of consciousness due to acute global impairment of cerebral blood flow. So basically क्या हो रहा है? Suddenly blood flow to the brain has been impaired or reduced. And please remember, I'm using the term global here. What is the meaning of term global here? Global refers to whole of the brain, not one particular area. So if I suddenly cut down the blood supply to only one particular area of the brain, right, that would lead to either development of an ischemic stroke or a transient ischemic attack. We won't be calling it as syncope. So when the whole of the whole of the brain, the blood supply is cut off acutely, that results in syncope. So syncope is transient, self-limited loss of consciousness due to acute global impairment of cerebral blood flow. Okay, that is the basic definition. Now in this definition, there are three hidden terminologies. The first one is about the onset. The onset of syncope is always sudden. Syncope doesn't slowly occur, right? It is always sudden. Duration of a syncope episode is usually brief. The loss of consciousness does not last for more than 1 minute if it is a case of syncope. If it is lasting for 4 minutes, 5 minutes, it is unlikely to be a case of syncope. And the third thing, see, suddenly someone has lost consciousness for a brief period and then he will recover the consciousness. Once he recovers the consciousness, will there be any residual manifestations? Like for example, you might have heard about something called as Todd's palsy, right? Where do we see that Todd's palsy? We see Todd's palsy following a seizure episode, right? Whenever someone has a convulsion, after that he can have profound weakness of the body. That is because during seizure episodes, all the ATPs available in a muscle is used up for that contraction. Now muscles do not have any more ATPs, so they will not be able to show the strength. That is why we end up with weakness. That's what we call as Todd's palsy. So it is a post-seizure sequelae happening after the seizure. You might have witnessed many seizure episodes in your hospital and even outside the hospital. And one thing you can closely observe, that most of the patients, when they recover from seizure, they remain drowsy for quite some time. Right, they're not back to full normalcy soon after they recovered from the seizure. Most of them will remain drowsy. But what about syncope? Syncope, the recovery is spontaneous and complete. Is spontaneous and complete. Yes, Satya, absolutely right. So that's what we call as post-ictal consequences or sequelae, which includes post-ictal confusion, Todd's palsy, and many other complications. We don't see those in syncope. So syncope is transient, self-limited loss of consciousness which is due to acute global impairment of cerebral blood flow. Syncopal episodes, or this loss of consciousness, happens suddenly. It is only for a brief period, and after that there is a spontaneous, means without any intervention, there is a spontaneous recovery, and the recovery is complete, means you don't have any weakness, any confusion or anything. You are back to full normalcy after an episode of syncope. Okay, now what can cause syncope? To understand the cause, right, first we have to get the basics right. What can lead to acute global decrease of blood flow to the brain? See, if I have a small clot in the middle cerebral artery, then only the middle cerebral artery territory will not be getting the blood supply. if I have some dissection of an aneurysm in the anterior cerebral artery, then only the anterior cerebral artery territory will not be getting the blood supply. But if the whole brain, the blood supply is diminished or cut off, what could be the reason? Once we understand that reason, then understanding the syncope becomes easy. See, what is the possible reason? Most importantly, when the cardiac output is reduced, the amount of blood coming to all the blood vessels going into the brain will come down, right? So when cardiac output is reduced, that can happen. What all can reduce the cardiac output? So if I have a problem with the heart, obviously it can reduce the cardiac output, and those conditions we call it as cardiogenic syncope. That we will discuss later. Okay. But I will tell you one important statement. Just listen to the statement and then tell me what could be the possible reason. Majority of the syncopes generally happen when the person is in sitting or standing position and not in a lying down position. Most of the syncopes happen when the person is in standing position or maybe in sitting position, and very rarely when he is in a sleeping position. What could be the reason? Well, so remember, when we keep our body upright, right, generally when we are standing, because of gravity, almost around 500 ml to 1000 ml of blood gets pooled in the lower limb veins. And that is an unfortunate change that we have adapted to as a species, right? When we were four-legged animals and then we metamorphosed to become a two-legged animals, we assumed an upright posture. That brings certain challenges, right? One of the challenges is that when we are in upright posture, there is pooling of blood in lower limb veins. Blood in lower limb veins. How much blood gets pooled there? Almost around 500 ml to 1000 ml, means half a liter to 1 liter blood is now pooled in your lower limbs when you stand up. That much amount of blood is not coming to the heart, it is getting pooled in the lower limb veins. So what will happen to the amount of blood coming back to the heart? What we call as venous return, right? From your tissues, the blood coming to the heart, that will come down because it is all getting pooled in the lower limb. So there will be decrease in the venous return. If the amount of blood coming to heart comes down, the amount of blood the heart can eject will also come down. Simple, right? So then what will happen to the cardiac output? This will decrease the cardiac output. So that is why whenever we stand, our cardiac output drops transiently. And please remember, the blood pressure, especially the systolic BP, is directly proportionate to stroke volume. So if the cardiac output is decreased, it means that the stroke volume is decreased. So that means our systolic BP is going to decrease. The BP is supposed to drop when we stand. But obviously low BP is not acceptable to our tissues, right? It needs sufficient perfusion. So to maintain that, we have a counter regulatory mechanism. What is that? When BP drops, it will activate what we call as baroreceptors. Where do we find the baroreceptors? We find them in carotid sinuses, right? And the arch of aorta. Arch of aorta. These are our BP sensing mechanisms. So they get activated. Once the carotid sinus and the arch of aorta, the baroreceptors there get activated, it increases the sympathetic outflow. Means the sympathetic nervous system activity will increase, and the vagal tone, which is nothing but parasympathetic nervous system, part of the parasympathetic nervous system, that will decrease. Okay. So normally what happens if the sympathetic nervous system gets activated? What will happen to the blood vessels? The blood vessels will get constricted, right? So the peripheral vascular resistance will increase. And because of the constriction of the blood vessels, even the reverse flow to the heart will increase. So there will be increase in the venous return, and thus the cardiac output would also increase. Similarly, when I decrease the vagal tone, what will happen to the heart rate? Vagus nerve decreases the heart rate. If I decrease the vagal tone and the sympathetic nervous system activity on the heart is increased, so the heart rate will increase. If the heart rate increases, what will happen to the cardiac output? The formula for cardiac output is stroke volume into heart rate. Sympathetic nervous system would have stimulated the ventricle to contract more, so that will definitely increase the stroke volume. And by inhibiting the parasympathetic nervous system or decreasing the vagal tone, we have increased the heart rate. So when both of these components are increased, the cardiac output will also increase, right? So this will correct the hypotension that we had. So these changes will counter the hypotension that we had, right? They will help us to normalize the blood pressure. And thus now the blood pressure is back to normalcy. So even when I'm sitting and get up, My BP theoretically is supposed to drop, but the counter regulatory mechanisms will help me to maintain it. When there is an impairment of this counter regulatory mechanism, that is where I will not be able to push up the cardiac output, I will not be able to normalize the blood pressure, and what is the outcome? The amount of blood that goes to the brain would come down and I can end up in syncope, right? So in simple words, I would say majority of the cases of syncope are either because of cardiac defect or because of impaired mechanism of blood pressure regulation in upright posture. That is the reason for syncope. So based on this concept, the causes of syncope are classified into three groups: neurally mediated syncope, orthostatic hypotension, and cardiac syncope. Okay, so first we will address cardiac syncope. Cardiac syncope means either you have a structural heart disease or some rhythm disturbance, and because of that the cardiac output is getting reduced. So in simple words, decreased cardiac output because of either structural heart disease. So when I say structural heart disease, which heart diseases can cause decreased cardiac output? Which heart diseases can cause decreased cardiac output? Which valvular diseases? Can anybody give me an example? So let me say this is my left atrium, this is my left ventricle, right? This is my aorta. So this is aorta, this is left ventricle, this is left atrium. Normally what happens, the oxygenated blood comes to the left ventricle and from there it gets ejected to aorta, right? So whatever amount of blood that left ventricle ejects in one systolic contraction, that is what we call as stroke volume. I multiply it with heart rate and that gives me the cardiac output, right? So if I have a narrow opening of the aortic valve, in that case what will happen? Even if my left ventricle contracts well, it will not be able to eject sufficient quantity of blood into the aorta because the opening of the aortic valve is narrow. Absolutely right. So aortic stenosis is an important cause. Okay. Then anything else which is very similar to aortic stenosis in terms of the pathophysiology? What if I have a thick interventricular septum? Instead of having the problem at the level of aortic valve, the problem is in the interventricular septum, but ultimately interventricular septum is creating an obstruction for the ejection of blood from left atrium to left ventricle to aorta. What we call that condition as hypertrophic obstructive cardiomyopathy, right? Okay, then can I have reduced cardiac output if I have mitral stenosis? So here we have a mitral valve, right? If the mitral valve opening is narrow, then what will happen to the amount of blood that fills the ventricle during the diastole? That will come down, right? So if there is less filling of the ventricle, then what will happen to the ejection? If ventricle receives less amount of blood, it can only eject less amount of blood. So can mitral stenosis cause reduced cardiac output and the syncope? Yes, it can. Mitral stenosis. So these are three important structural heart diseases that should come to your mind whenever you think of a patient with cardiogenic syncope. Okay. Apart from that, there is another condition which can lead to syncope, that is arrhythmias. Have arrhythmias will lead to syncope? Well, when we talk about arrhythmias, there are two types: bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias are conditions where heart rate is very low, right? Less than 60, very low. So if heart rate is low, right, what will happen to the cardiac output? Cardiac output is equal to stroke volume into heart rate. So let me say I have developed a complete heart block and my heart rate is 25. In that case, will I be able to maintain a good cardiac output? This is the formula for the cardiac output. So if the heart rate decreases, even if I maintain the stroke volume, the cardiac output is going to drop, right? So give me examples for bradyarrhythmias. Yes, SA nodal diseases. So if the SA node itself is dysfunctional, I can have bradyarrhythmia, right? SA nodal diseases and the AV blocks, atrioventricular blocks. You might have studied about first degree, second degree, third degree AV blocks. All of them can cause reduced cardiac output. The main mechanism behind that is decrease in the heart rate. Okay. And then when it comes to tachyarrhythmias, you have two types of tachyarrhythmias. Supraventricular arrhythmias, where the arrhythmia originates mainly at the level of atria. And then we have ventricular arrhythmias, where the arrhythmia originates in the ventricles. Traditionally speaking, it is the ventricular arrhythmias which are known to cause syncopes. Okay. Why ventricular arrhythmias will cause syncope? See, whenever the ventricular rate is high, see, if I have to increase the heart rate, one cardiac contraction means we have a systole, and then we have a diastole. So if I have to increase the heart rate, I have to either shorten the systole or I have to shorten the diastole. Normally, which one gets shortened? It is the diastole, which progressively gets narrowed as the heart rate starts increasing. So if the diastole time is becoming narrow and narrower, shorter and shorter, the time available for us to fill the ventricles from atria goes on decreasing. So if I have less time to fill the ventricle, I will fill only less quantity of blood. So if at the start of systole I have less quantity of blood in the ventricle, then I will be able to eject only less quantity of blood, right? So the cardiac output indirectly, or in other words I would say stroke volume indirectly depends on how much blood is there in the ventricle at the end of diastole. That is what we call as end diastolic volume. So if I decrease the end diastolic volume, then the stroke volume will decrease. So if I don't fill the ventricles sufficiently, then I can't expect sufficient stroke volume, thus sufficient cardiac output won't be there. So these are all causes for cardiac syncope. Okay. Then we have two conditions left, that is neurally mediated syncope and orthostatic hypotension. The neurally mediated syncope is also called as, this is also known as vasovagal syncope. Vasovagal syncope or reflex syncope See, typically this is very common. In fact, most of us would have experienced ourselves, like you had a thorn prick in your leg and then someone was trying to remove the thorn and suddenly you go blank, or you heard a happy news or a very sad news and then suddenly patient collapses. Those are all mostly neurally mediated, or what we call as vasovagal syncope. Okay. And then we have another condition called as orthostatic hypotension. The mechanism of cardiac syncope was pretty simple, right? You have either a structural problem with the heart or you have rhythm problem with the heart. Because of that, you're not able to generate good cardiac output. And because you're not able to generate good cardiac output, good amount of blood is not coming to your brain, and that is why you're losing the consciousness, right? The mechanism of onset of syncope in these two conditions depends on what we discussed in the pathophysiology. So whenever we have an upright posture, we are supposed to have decrease in blood pressure, but that is countered by the activation of baroreceptors and modulation of sympathetic nervous system outflow, increasing the outflow of the sympathetic nervous system, decreasing the activity of the parasympathetic nervous system. We are able to normalize the blood pressure, normalize the cardiac output. If this mechanism gets transiently impaired, means not a long-term disturbance of this mechanism, this is functionally fine, but for some reason, like when you are experiencing pain, your vagal nerve becomes hyperactive. Like see, we do these maneuvers called as Valsalva maneuver, right? For what purpose we do that? To activate the vagus nerve, right? Whenever we are dealing with some arrhythmias in the treatment, we use this Valsalva maneuver. We activate the vagus nerve. We ask the patient to exhale with the closed glottis, or in other words, mouth and nose closed, we ask them to exhale. That's a vagal maneuver, and there are various modifications of it available, right? But if something similar to that happens without we voluntarily doing it, right? If vagal nerve gets hyperactive because you were exposed to painful stimuli, or you were exposed to a very painful news, right? A bad news, sorrowful news, then your vagal nerve can become suddenly activated. And when it gets activated, what will happen? Once the vagus nerve gets activated, it will lead to bradycardia, because heart rate comes down, and that will lead to decrease in cardiac output. So if the cardiac output decreases, we can have an episode of syncope, right? But because that is a very transient increase in activity of the vagal tone, as soon as the vagal tone normalizes, the heart rate gets normalized, cardiac output gets normalized, and patient will regain his consciousness, right? That is one possibility. The other possibility is you can have the chronic impairment of this mechanism. Chronic impairment of the baroreceptor response. So if chronic impairment is there, then whenever you stand, every time you can experience a syncope, and that condition is what we call as orthostatic hypotension. So the primary mechanism here is impaired baroreceptor response. Impaired baroreceptor response. In case of neurally mediated, it is transient. Most likely hyperactivation of the vagus nerve. And in patients with the orthostatic hypotension, it is permanent, means persistent, not transient. The mechanism of orthostatic hypotension is also same, but it is persistent, or in more precise words, I would call it as chronically impaired baroreceptor response lead to orthostatic hypotension. So what is the meaning of orthostatic hypotension? When you suddenly stand up, right? Upon standing up, your blood pressure is expected to drop, but your counter-regulatory mechanism is expected to normalize it. But if your counter-regulatory mechanism is chronically impaired, then whenever you stand, your blood pressure drops and you do not quickly recover from it. You decrease the blood supply to your brain, you drop down or you collapse, you lose the consciousness, and then because you're dropped down to the floor, the baroreceptor mechanism is no longer required, the venous return to the heart improves, cardiac output improves, and then you will regain the consciousness. This is what we call as orthostatic hypotension, for which we have an objective definition, right? How do we define the orthostatic hypotension? Can anybody tell me the definition of orthostatic hypotension? Meanwhile, I'll quickly take you through what Harrison talks about so far, whatever we have discussed. So I want one of you to comment the objective definition of orthostatic hypotension. Concept wise, I have told you. Orthostatic means on standing blood pressure drops. That's a basic thing, right? Okay. Getting back to Harrison. What Harrison says, syncope is transient self-limited loss of consciousness due to acute global impairment of cerebral blood flow. We have looked into it, right? The onset of syncope is usually rapid or sudden. The duration is brief and recovery is spontaneous and complete. Okay, so if you have any patient who has lost consciousness, but the loss of consciousness was gradual, slowly, right, over several minutes to several hours, that is not syncope. If any patient who has lost consciousness, but it persisted for a pretty long period of time, then it is not syncope. Any patient who has lost consciousness, if he did not recover spontaneously without any intervention and the recovery was not complete, patient is left with certain residual weakness, it is not syncope, right? Okay. So as I discussed, syncope is classified into neurally mediated, which is also called as reflex or vasovagal, orthostatic hypotension, and cardiac. Okay. Now, in terms of pathophysiology, I think I've already told you, upon standing, around 500 to 1000 ml of blood gets pooled in the lower limb veins, and because of that, the amount of blood returning to heart comes down. If the less amount of blood comes to heart can only eject less amount of blood. Whatever comes to it, only it can eject. It won't synthesize any blood of its own. So if less amount of blood comes to heart, less is the ejection. So in other words, I would say there is decrease in cardiac output, and if the cardiac output decreases, your blood pressure is expected to decrease, the perfusion of your organs including brain is expected to decrease, but there is a compensatory reflex response primarily mediated by baroreceptors in the carotid sinus and aortic arch, which will increase the sympathetic activity and decrease the vagal activity. So by increasing the sympathetic activity, we will cause vasoconstriction, increase the heart rate, and by decreasing the vagal tone, we will counter it, in the sense we will increase the heart rate, we will achieve a better blood pressure, right? So that is our mechanism or a defense against drop in blood pressure on standing. How much time this response will take once I stand suddenly? Now I'm sitting. If I stand suddenly, how much time this will take, this compensatory mechanism will take to get activated? It will take around 5 to 10 seconds. Around 5 to 10 seconds. That's more than enough for the BP to get normalized upon getting up from a sitting position. But if this mechanism is impaired, right? If I have issues with the heart, I am not able to generate cardiac output, or if I have issues with this baroreceptor sensing mechanism, this compensatory reflex that we were triggering, then I will not be able to increase the blood pressure, and thus that decreased blood pressure, decreased cardiac output will result in decreased blood flow to the brain, and I will lose the consciousness, right? Okay. Now, in terms of classification, first thing we studied was cardiac. We will go there, but let us see what Harrison says about neurally mediated syncope or reflex or vasovagal syncope. The neurally mediated syncope is usually subdivided based on afferent pathway and the provocator trigger. Means neurally mediated syncope always carries a trigger. Means either hearing a good news or a bad news or receiving a painful stimulus or a shocking event. there is always a stimulus involved. Okay, and among them, this is the most common syncope, and it is like when, because it has a trigger, we will always call it as a provoked trigger. So intense emotion, pain or stress, they can be the triggers. But apart from that, there is a subtype of neurally mediated syncope which is called as situational syncope. Satya is IIM is absolutely right. But I want you to comment about the time. Means after standing, the BP drops after how many minutes, to call it as orthostatic hypotension. Okay, so there is a subtype of neurally mediated syncope. Most common neurally mediated syncope is where upon hearing a emotional news or a painful stimuli, patient develops a syncope. But there is something called a situational syncope, where a localized provocative stimulation can cause vasodilatation and bradycardia by activating the vagus nerve. Examples are, like example for situational syncope is what you need to remember. Many times after coughing, patients develop syncope, right? It is called as post-tussive syncope. Post-tussive syncope. Tussive refers to cough. You cough vigorously and then you lose consciousness for a while and then you wake up. That is one example for a situational syncope. Okay. Then Harrison gives you a table of causes for neurally mediated syncope, where the vasovagal, which is the most common type, which is usually provoked by fear, pain, anxiety, same thing that we were talking about, which is obviously the more common scenario. Apart from that, situational syncope, I was giving you an example of a cough syncope or post-tussive syncope. That is an example. Similarly, many people can experience syncope after passing urine. In that case, it is called as post-micturition syncope. Again, the reason behind that is while passing urine, your vagus nerve gets activated. Then in physiology, you might have studied about carotid sinus hypersensitivity. So this carotid sinus can be hypersensitive. Sometimes while shaving, also it can get triggered and they can experience an episode of syncope, right? And then there is a ocular syncope, where the pressure on the eyeballs again can activate the vagus nerve. That can also cause syncope. Apart from this, many of us can experience a syncopal-like episode on trying vagal maneuvers like Valsalva or modified Valsalva, which are again neurally mediated syncope. Okay, then coming to the second type that we were talking about, orthostatic hypotension. Definition is absolutely right. Orthostatic hypotension refers to drop in systolic BP by more than or equal to 20 millimeters of mercury. This is something that examiners routinely ask during the bedside discussions. Or diastolic BP by more than or equal to 10 millimeters of mercury 3 minutes after standing. 3 minutes after standing. This is a objective definition of the orthostatic hypotension. So if your systolic BP drops by more than 20 millimeters of mercury, or diastolic BP drops by more than 10 millimeters of mercury after 3 minutes of standing, then it is called as orthostatic hypotension. So basically what we do is we check the patient's blood pressure first in the supine or recumbent position. Then we will make him stand. After 3 minutes, we will recheck the BP again. And if it is dropped by more than 20 systolic or more than 10 diastolic, then we can classify the case as orthostatic hypotension. And these are the patients, whenever they get up, they have a tendency to experience an episode of syncope. Okay, so now we have understood the causes for the neurally mediated syncope, right? Vagal nerve hyperactivation because of emotion, painful stimuli, stress, anxiety, or situational syncope where vagus nerve is getting activated because of certain situations like vigorous coughing, micturition, ocular pressure, or other vagal maneuvers like Valsalva. Okay. What could be the cause for orthostatic hypotension? See, here it is simple. Why there was impaired baroreceptor response? Because the vagus nerve was transiently activated by whatever acts we did or whatever situations we went through. But orthostatic hypotension, isko hone ke liye, there should be chronic impairment of the baroreceptor response. So what can chronically impair the baroreceptor response? Okay, so Harrison gives you a table First thing is the disorders which affect the autonomic nervous system. Disorders which affect the autonomic nervous system can cause orthostatic hypotension. So what are the disorders that can affect the autonomic nervous system? See, basically either your vagus nerve becomes hyperactive unnecessarily, causing bradycardia, vasodilatation, or your sympathetic nervous system becomes inactive unnecessarily, again causing bradycardia, vasodilatation, reduced venous return, reduced cardiac output, and syncope. That is the consequence, right? So there are some autonomic disorders, right? Especially the conditions are called as synucleinopathies. I think one of the synucleinopathy you're very much familiar with is Parkinson disease, and whenever I talk about Parkinson disease, I do talk about the autonomic nervous system dysfunction, right? Apart from Parkinson disease, there are other synucleinopathies which includes Lewy body dementia, pure autonomic failure, and multi-system atrophy, a subtype called as Shy-Drager syndrome. These are all disorders where autonomic neurons are degenerated. So if autonomic neurons are degenerated, there is impairment of the baroreceptor response mechanism, and because it is a chronic disease, chronically impaired, so patients can experience, whenever they stand up, they can experience fall of BP, fall of cardiac output, and episodes of syncope. Apart from that, we can also acquire autonomic nervous system dysfunction. The most common cause for acquired autonomic nervous system dysfunction is diabetic neuropathy. So when we say diabetic neuropathy, diabetes is not only affecting the peripheral nerves, means the conventional peripheral and the cranial nerves, it can also affect the autonomic nervous system. Okay. Then you might have also studied about autonomic neuropathy in hereditary amyloidopathies, right? So there is a long list of conditions where autonomic neurons can get affected secondarily, not primarily. Okay. Other than that, many of us have experienced this, what we call as postprandial hypotension, right? Means after eating food, all of us feel very dull, tired, sleepy. I think you have studied it in physiology also, because after eating food, the cardiac output significantly get diverted to the gastrointestinal tract, and the cardiac output going to brain comes down, and because of that we feel bit lightheaded, sleepy. But in some people it can be over exaggerated, and in that case significant decrease in the cardiac output going to the rest of the organs, and most of the cardiac output getting diverted to GIT means that your BP will fall and you can experience episodes of syncope. But the most common cause for orthostatic hypotension today is the drugs, antihypertensive drugs. To be more precise, it is the antihypertensive drugs, because antihypertensive drugs are trying to modulate this baroreceptor response mechanism, and they can cause orthostatic hypotension. Many a times, especially alpha blockers, beta blockers, we might have to think of withdrawing them because they are causing the orthostatic hypotension. And the last one, but not the least, it is dehydration or volume depression. They can also cause the orthostatic hypotension. So these are all causes for what we call as orthostatic hypotension. Okay. So now, before I talk to you a little bit about the treatment, again let me summarize what all can cause syncope. Syncope refers to transient self-limited loss of consciousness due to diffuse or global impairment of blood supply to whole of the brain. That typically happens when the reduced cardiac output happens. Reduced cardiac output can be because of cardiac disorders where there is obstruction to the ejection of blood from left ventricle because of structural heart diseases like this, or because of arrhythmias, right? Or it can also be happening because of impaired baroreceptor response mechanism that we just discussed. Whenever we stand or we are in erect posture, there is pooling of blood in the lower limbs, and because of that there is reduced venous return to heart, so that causes hypotension. To counter that, we have baroreceptors which activate sympathetic nervous system, inactivate parasympathetic nervous system. That helps us to counter it. If we have a transient impairment of it, we get neurally mediated syncope, and if there is persistent impairment of it, we get the orthostatic hypotension. Okay. Okay. Now, the real concern is transient loss of consciousness can happen in various other conditions. So how do I get to know that this particular patient is having syncope only? So once I know that this is syncope, it is not very difficult for me to identify whether patient has got orthostatic hypotension, or whether it is cardiogenic syncope, or whether it is vasovagal syncope. If on examination I get abnormalities of the cardiac function, right, I hear a murmur or something like that, then I would evaluate more in the direction of cardiac syncope. If On examination I can prove that patient has got orthostatic hypotension, then I would probably look into the drug history and see if patient is on any drug which is known to cause orthostatic hypotension, or if the patient is having any of the autonomic nervous system dysfunction, like either primary synucleinopathies or secondary like diabetic neuropathy, amyloidosis, I would think of, right? But first step would be to confirm that what I'm dealing with is a case of syncope, and the closest differential diagnosis that comes to syncope is a seizure. So how do I differentiate between seizures and syncope? First and the most important point is triggers, right? Syncope, because vasovagal or neurally mediated is most common, right? Intense emotions, right? Pain, fear or anxiety, right? Or long standing are potential triggers. So usually patient would say that I got to know that my parent or someone had died and then suddenly he lost the consciousness, or he was watching a cricket match, ball came and suddenly hit him and after that he lost the consciousness. So you will generally be able to elicit this history of trigger, right? So these emotions, pain, these are not potential triggers for seizures. Seizures also there are triggers, but those are like the missing of the anti-seizure medications, that's the most common trigger. Then exposure to electrolyte, like developing electrolyte abnormalities, or the drugs which lower the seizure threshold, they are the triggers. The conventional triggers are not expected in a patient with seizure. Okay. The second differentiation would be abnormal movements. Okay. So can anybody tell me whether syncope patients show abnormal movements during an episode of syncope or not? So when someone is going through syncope, will he have abnormal movements or not? I know most of you would answer, sir, seizures they will have abnormal movement, and syncope they will not have abnormal movements, which is the biggest mistake that we do in front of the examiners. Okay, so examiners will come out with two counter questions. One, you might have heard about something called as absence seizures, right? Do they have abnormal movements? No, right? Then the second thing the examiner will say is that abnormal movements can happen in the patients with syncope also, right? So in syncope, what kind of abnormal movements we expect? We generally expect myoclonic jerks. And what is the most common seizure type? The most common seizure type is generalized tonic-clonic seizures, or what you call as GTCS. So if it is GTCS, what kind of movements we will get? We will get what is called as tonic-clonic movements. Tonic-clonic movements. So can anybody explain me what is the difference between a tonic movement, a clonic movement and a myoclonic jerk, and also fibrillation or fasciculations? What do you think? What is the difference between, okay, what is tonicity? Tonicity refers to sustained state of contraction. So let me say triceps, right? If my triceps is continuously contracted, now my elbow is in continuous extension, my triceps is continuously contracted. This is tonic state. Clonic means jerky movement, right? Jerky movement. Tonic is sustained state of contraction, clonic is jerky movement. So in a patient with seizures, generally you will have tonic or a sustained state of contraction followed by jerky movement. That's why it is called as tonic-clonic movements. In patients with syncope, you will only have jerky movements, you will not have a tonic phase, right? You will not see a patient with syncope going like this, sustained state of contraction and then throwing the jerky movements. A seizure patient first goes into a tonic state, right? All his muscles become stiff and then he starts throwing the jerky movement. That is one difference. But then another point is, you might have come across a term called as fasciculations. Like whenever you have this lower motor neuron damage, we get fasciculations, right? So what is the difference between fasciculations and myoclonic jerks? Myo means muscle, clonic means clonic, right? Jerky movements. What is the difference between myoclonus and fasciculations? So please remember, when muscles contract, right, involuntarily, if the contraction is small or weak and none of the joints move, then it is called as fasciculations. Like for example, if my biceps contracts but my elbow doesn't move, I can see that biceps is contracting little bit involuntarily, but my elbow joint is not showing any movement. Such movements will be called as fasciculations. So we see fasciculations typically when there is a lower motor neuron damage. Okay, but when you say clonus, that means the concerned joint moves. The biceps contracts to an extent that the elbow joint is moving. Then we call it as myoclonus. So here we can see myoclonic movements. In seizures, generally we see tonic-clonic movements. But I said generally because there is also myoclonic type of seizures. That is a very close differential diagnosis, and it is difficult to differentiate between myoclonic seizures and the syncope. In such cases, we have to rely on investigations. Okay. Now, what happens prior to an episode of syncope or seizure? Prior to an episode of syncope or seizure, these patients go through what is called as pre-syncope. Pre-syncope, which is also called as premonitory phase. Okay. And usually patients with seizures go through aura. Now, what is the difference between pre-syncope or aura? No, myoclonic and clonic both are same. Myoclonic and clonic both are same. Myo basically refers to muscle. Okay, so when there are jerky movements strong enough to move a joint, whichever muscle is showing that abnormal movement, if it is strong enough to move a joint, right, result in contraction or extension of a joint, it is called as clonus or myoclonus. Myo because the muscle comes into picture. Tonic means stiffening or sustained state of contraction. Whatever is the muscle, right? If my biceps is in a sustained state of contraction, contracted only, not showing the jerky movements, contracted only, that is tonic. If it is showing jerky movements, that is clonic, right? Clonic is also called as myoclonic. So here, because only clonic movements are seen, I have written it as myoclonic jerks. Here, because both tonic and clonic are seen, we have written it as tonic-clonic movements. Okay. So usually before syncope, patients often experience lightheadedness, fatigue, right? These are common symptoms for few seconds before patient loses the consciousness. So this phase is what is called as pre-syncope. So usually story goes like this: patient hears a bad news, right? After that he feels little dizzy, lightheaded, and experiences extreme weakness, then loses the consciousness, right? But if it is a patient with seizure, often they have aura. So in aura, what happens? Patients with seizure, right? Before the beginning of seizure, they go through a phase called as aura, where they can have abnormal sensory perceptions. Sensory perceptions means in their visual field, they can see flashing of lights, right? They can hear ringing of some sound, right? Hissing noise. They can have gustatory aura where they start smelling, they can have olfactory aura where they start smelling weird smells, or they can have gustatory aura where they start experiencing abnormal or weird taste in the mouth with no stimulus being present. We call that phase as aura. After the aura phase, patient starts developing the seizures. So before the seizure, a patient will have aura. Before the syncope, patient will have pre-syncope. So in pre-syncope, generally we do not experience those sensory perceptions. Only some degree of lightheadedness and fatigue. Now after patient has lost consciousness, whether it is seizure or whether it is the syncope, patient will regain the consciousness, right? So when he is regaining the consciousness, the recovery in seizure, right, it is characterized by post-ictal phase. What we call as post-ictal phase, where patients will have confusion, right? Generally they will be drowsy or confused. They will feel weak. We get aura in migraine as well as seizures. Quite similar experiences patients with seizures will also go through. Drowsy or confused, so we can call it as post-ictal drowsiness or post-ictal confusion, right? They can experience weakness, and when it is severe enough, we call it as Todd's palsy. Okay. But recovery in patients with episode of syncope, right, is always spontaneous and complete. So whenever someone experiences syncope, right, once they are back to their consciousness, they're fully normal. They don't experience any more weakness, any fatigue, right, any tiredness. They're fully back to normal. This would have happened to many of us, right? Many of us, while suddenly getting up from a sitting position, feel dizzy. We sit down, and then after a few seconds we're back to full normalcy. But patients with the seizures, they will remain drowsy or confused for a very prolonged period of time. And I forgot to mention one more important point. The loss of consciousness that happens in syncope generally lasts for less than 1 minute. Before that, there is regaining of the consciousness. The loss of consciousness that happens in patients with seizures often lasts for more than 5 minutes. Okay. And then last but again equally important point, bowel and bladder incontinence. Can patients with syncope experience bowel and bladder incontinence? See, one of the common questions that we ask during our emergency room case taking is that when patient lost consciousness, did he pee or shit in his clothes, right? This is one of the common questions that we ask. Apart from that, we also ask about the tongue bites, right? So please remember, tongue bite is not a definitive sign of seizure. Even patients with syncope, they can experience tongue bites, because while an act of falling, the tongue may not be positioned within the oral cavity. It may be stuck between the two teeth and it can cause tongue bite. So tongue bite is not a definitive sign of seizure. Similarly, please remember, incontinence is also not a definitive sign of seizure. Even syncope can cause incontinence. But typically what happens is, in syncope, we will only experience urinary incontinence. Most of them, some of them might pee in their pants when they experience an episode of syncope. So urinary incontinence can happen, but in patients with seizure often there is fecal as well as urinary incontinence. We don't get to see fecal incontinence commonly in patients with syncope. So that is why if you ask me, sir, tell me few points that can really help me to differentiate between autonomic features can be found in both in syncope as well as the seizures, because in syncope what is happening, it is your autonomic nervous system going dysfunctional, which is the reason why you are getting syncope, but obviously the body will try to counter it. So we can experience autonomic symptoms prior to syncope, prior to seizures. So that's why it is not a very reliable point. Okay. So if you ask me to point out the most important point that will help us to differentiate between seizures and syncope, one is the duration of loss of consciousness, right? Slightly prolonged for seizures, very short for the syncope, that is one. Second, presence of aura prior to the onset of seizures in patients with seizures. We don't see that in patients with syncope, right? Third, and the most important, is the recovery phase. So if someone loses consciousness for a few seconds and after that he is fully normal, it is most likely syncope. If someone loses consciousness but after that he is tired, confused for quite some time, it is most likely seizure. And if patient has fecal incontinence during the episode, again it is strongly favoring the seizure as a possible diagnosis, right? Okay. Now apart from this, there is one more differential diagnosis, which is hypoglycemia, because hypoglycemia, same sequence of events happen. When the blood glucose level starts dropping, right, we start experiencing lightheadedness, fatigue, tiredness. So the pre-syncope like event happens in patients with hypoglycemia also. In hypoglycemia also, to increase the blood glucose level, our sympathetic nervous system, adrenaline, everything is getting shot up. So we can have tremors and all those sympathetic symptoms. And then when the blood glucose level fails to correct, we will lose the consciousness. Similar, right? Clinically, it is very difficult to differentiate between syncope and hypoglycemia. And that is why every time you deal with a patient with syncope, it is a default rule that you should check the patient's blood glucose level. Clear? So now I will tell you the causes, right? What are the causes? Neurally mediated, orthostatic, and cardiac syncope. So you should now tell me. Okay, I'll tell you. Yeah. So you should now tell me what investigations you want to do in a patient with who presented with syncope, so that you can differentiate these causes and come out with the final cause, right? Whether it is orthostatic hypotension, or whether it is cardiac syncope, or whether it is neurally mediated syncope. And you have to also rule out closely related differential diagnosis like your hypoglycemia and seizures. So what all investigations you will do? Yeah. So this supine hypertension is one of the manifestation, and I would also say complication, of orthostatic hypotension. So those patients, especially those who have autonomic nervous system dysfunction, For example, patients with multisystem atrophy or Shy-Drager syndrome, Parkinson disease, or diabetic autonomic neuropathy. In all of them, because they have orthostatic hypotension, so when they stand up, their BP falls, right? So their autonomic nervous system is trying to counter it, but it is failing. So BP falls, patients experience the syncopal episodes. But now that your sympathetic nervous system is hyperstimulated during this orthostatic hypotension, when you lie supine after this, your BP will be higher. Supine hypertension is usually encountered in patients with orthostatic hypotension. So these people, when they are sitting or erect, their BP will be significantly low, but when they are supine, it will be significantly shooting up. Okay, so what investigations you would like to do that helps you to differentiate between seizure, syncope, and also help you to understand individual causes, right? So first investigation that I would suggest you should do in any patient with syncope is the blood glucose level, right, or plasma glucose level. Blood glucose levels, because it is difficult for us to clinically differentiate between an episode of hypoglycemia and an episode of syncope, because similar flow of events happen, right? Second, cardiogenic is always an important differential diagnosis because they are potentially treatable, and non-treated they contribute to mortality, right? So what investigations that can help me to identify a cause of cardiogenic syncope? Echocardiography can help me to identify structural heart diseases, right? If I have aortic stenosis, hypertrophic obstructive cardiomyopathy, mitral stenosis, echo can identify. Which investigation can help me to identify an episode of arrhythmia? If patient had gone through a transient period of VT or VF, and because of that the cardiac output has gone low and he had developed a syncope. Which investigation can help me identify whether a patient has got an arrhythmia or not? See, if patient presented with syncope, it means two things. If it is cardiogenic and if it is because of arrhythmia, most likely it means that the arrhythmia was transient, or what we call as paroxysmal. If the arrhythmia persisted, he wouldn't have recovered from syncope. He would have gone into hypotension and eventually arrested. So if he presented with an episode of syncope, but now he is back to normalcy and consciousness is fine, that means the arrhythmia that occurred is no longer there. So if I do an ECG right now, will I be able to identify that arrhythmia? Yes, VF happened transiently. I lost the consciousness and then the VF disappeared. So that is why the cardiac output improved. I'm back to consciousness. Now I'll come to you in the clinic and you're suspecting the possibility. But if you do the ECG right now, it will show normalcy, right? So then what investigation can help me to identify whether I had an arrhythmia or I have the tendency to have an arrhythmia? So we can now record the ECG continuously for 24 hours or even longer. So during that period, whenever an arrhythmia happens, it will document it. So that ECG is called as Holter monitoring. Holter monitoring. Okay, so blood glucose is one essential, echo is essential, ECG or Holter monitoring is essential. Cardiac syncope is not difficult to diagnose. Most cases of cardiac syncope are like telltale clinical cases. Like if I have aortic stenosis, the typical story goes like this. The most common cause for aortic stenosis is age-related degeneration of the aortic valve. So most of them will already be elderly, in their 60s or 70s. Second, the patient will often have other symptoms of aortic stenosis. What other symptoms? The symptoms of aortic stenosis, I usually abbreviate it as ASD. ASD stands for angina. These patients often experience anginal episodes, they experience syncopal episodes, and they experience dyspnea on exertion. Right? So this is what we call as triad of aortic stenosis. So if patient has all these three symptoms, can it be because of vasovagal syncope? No, right? Can it be a simple autonomic nervous system dysfunction leading to orthostatic hypotension? No. Then how would I explain angina if it is orthostatic hypotension? How would I explain dyspnea? Not possible, right? So when I see these three things together and the moment I put the stethoscope in the aortic area, I will be able to clearly hear the murmur. So it's not very difficult, right? Similarly, if I have hypertrophic obstructive cardiomyopathy, even if patient is asymptomatic, the murmur may be evident, right? Or the family history of sudden cardiac deaths may be evident. So cardiac syncope is not very difficult to diagnose, provided we know the basics and we know the right approach. But once you diagnose, the prognosis among all the three types of syncope, the cardiac syncope carries the worst prognosis because you have a major problem. You have either a structural problem or you have intermittent arrhythmias, both increase your risk of mortality. That is why we say patients with cardiogenic syncope have the worst prognosis and highest mortality, and patients with the vasovagal syncope, they have the best prognosis, because most of the vasovagal syncope are triggered by the emotional shocks or the painful stimuli. Okay. Now, if I am still confused to differentiate between a seizure and a syncope, in that case, I can rely on the EEG, right? So these are the minimal investigations that we need to identify the cause of syncope more precisely and rule out closely related differential diagnosis. Okay, a little bit about the management of syncope before we wind up. So if I am dealing with a patient with neurally mediated syncope or vasovagal syncope, in that case, the most important advice I would give to any patient with syncope is avoid the provocative stimuli. Means if painful stimuli is resulting in developing syncope or an emotional shock is resulting in development of syncope, the suggestion is that avoid doing those, right? Avoid exposing yourself to those situations. If cough is, every time you get cough you develop syncope, then give the cough suppressants and treat the underlying cause for cough. If post-micturition syncope is happening, right, then again we can train them to avoid the development of post-micturition syncope. Second thing, what we can do is we can teach them what is called as isometric counter pressure measures. See, ultimately every episode of syncope indirectly means that there is reduced cardiac output and thus reduced perfusion of the brain. So if I can increase the cardiac output somehow, then the syncope can be averted. So how can I increase the cardiac output? So one of the commonly practiced isometric counter pressure measure is hand gripping. So when patient feels that prodromal phase or the pre-syncope where he is feeling lightheaded, dizzy, we ask them to grip their hands tightly. What it will do? It will constrict all the blood vessels in your hand and forearm region. That increases the peripheral vascular resistance. Increased peripheral vascular resistance can give rise to rise in the cardiac output. Similarly, we can ask them to cross their legs. Crossing the legs also can help us to contract the leg muscles and push the blood that is pooled in the lower limbs towards the heart, right? So this hand gripping or crossing the legs, these can indirectly increase your cardiac output and thus they can help you counter if you're likely to develop a syncope. Can we use drugs for those patients who have repeated episodes of syncope despite, like you might have seen, right? Especially studies have shown that neurally mediated syncopes are more common in females. So you might have seen a lot of females in your classes or your junior classes where you just tell them some bad news or just pinch them with a painful stimuli and they collapse. Right? They will have an episode of syncope. That they don't tolerate bad news at all. Teachers भी घबराते हैं कुछ bad news सुनाने के लिए. Such is the situation, right? So for them what to do? We will tell them avoid provocative stimuli, but कहाँ से ये provocative stimuli, emotional news or a painful stimulus आने वाला है किसको पता? Right? चलते चलते they hit some rock on the road and then that itself can trigger an episode of syncope. In such cases what we can do? We can use drugs. The drugs include, there is a drug called as fludrocortisone. Can anybody tell me what is the mechanism of action of this? Fludrocortisone. Or you can use vasoconstrictors. Fludrocortisone is a aldosterone agonist. It's a long-acting aldosterone agonist. So what is the mechanism of action of aldosterone? What aldosterone does? Vasoconstrictors example I will give you is midodrine. Aldosterone agonist. Aldosterone stimulates your kidney to reabsorb sodium and water. So it does the exact same job but acting for a longer period of time. So when you reabsorb too much of sodium and salt, your plasma volume expands. So if the plasma volume expands, the end diastolic volume increases. If the end diastolic volume increases, the cardiac output increases. So that can help you to counter whatever drop of cardiac output that is going to happen whenever you are faced with an emotional stimuli or a painful stimuli. That is how we can manage a patient with neurally mediated syncope. If it is a case of orthostatic hypotension, right, treating the underlying cause is obviously important, but apart from that, we can think of certain non-pharmacological measures. Again, same thing, we can either give fludrocortisone to increase the plasma volume by absorbing more sodium and water at the level of kidneys, and we can give vasoconstrictors like midodrine. And non-pharmacological treatment wise, the most important thing is the posture training. The patients who have orthostatic hypotension, most of the syncopes happen when they are getting up from the sitting position, right? And that results in significant trauma and injury, especially if you're dealing with a patient with Parkinson's disease. Think of them, right? When they try to get up, they experience the orthostatic hypotension, they go blank, they fall, they sustain injuries, and most of the patients with Parkinson's disease are 70 plus. An injury, especially hip fracture at 70 plus, almost means that you are pretty much close to the door of death. Because once you develop a hip fracture, you are confined to bed, you develop other complications like bed sores, deep vein thrombosis, pulmonary embolism, and then you are inching towards death. So avoiding falls in elderly is very, very important. So what we do is we train them to take small steps in getting up. When they suddenly get up, your autonomic nervous system is not able to adjust with the situation and it is not able to rise your BP and you experience syncope. But if they slowly, stepwise make themselves upright, then they will not experience significant drop in the blood pressure. And we also tell them to avoid large meals, because whenever we take large meals, good amount of cardiac output is diverted to your GIT and less amount of blood goes to your brain, and we can experience syncope. So these patients who have orthostatic hypotension should avoid large meals and should slowly make the transition in the posture, and if required we can give them fludrocortisone or midodrine. Okay, so that is about the management of orthostatic hypotension, right, as a cause for syncope. And what if I have a cardiogenic syncope? Then obviously treating the underlying cause is important, right? For example, if the syncope is because of aortic stenosis, what is the definitive treatment? Syncope is because of aortic stenosis, right? Aortic valve replacement is the only treatment. If it is because of hypertrophic obstructive cardiomyopathy, if obstructive cardiomyopathy has resulted in syncope, then we have to either go for interventricular septum ablation with alcohol or laser, or cutting the septum which is causing the obstruction surgically, called as septal myomectomy. If I have a mitral stenosis, we can pass a balloon across the mitral valve and dilate it. We call it as balloon mitral valvotomy. So treating the cardiogenic syncope always depends on treating the underlying cause, right? If I have arrhythmias, what will be the best way to prevent development of syncope in a patient who is prone for arrhythmias? Yeah, Divyansh, after we finish the most cardinal symptoms, I think we will have another 6 or 7 sessions where we will finish most of the cardinal symptoms that we would encounter in our day-to-day APD, and then we will start with the examination, starting from basic pallor to icterus and all the system examinations. For that, we are planning to have individual patients or at least volunteers, so that I can demonstrate how is the examination done and what are the common mistakes that students do and how examiners catch those mistakes, so that you will be better prepared to face your practicals. Right, so if patient has got arrhythmias, the best way to prevent an arrhythmia again happening and thus leading to syncope is to put them on implantable cardioverter defibrillator. So there will be sensors which will continuously sense the rhythm of the heart, and the moment they notice that there is a VT happening or a VF happening, they will shock it, right? And if it is blocks, the best way to treat blocks would be to put them on pacemakers. For now, you don't need to really stress too much about the management of syncope, because individual diseases we will be discussing them as the time progresses. The take home message for today is learn how to differentiate between syncope and seizure, have the concept of syncope, right, how to define syncope, how to classify the causes for syncope, and few essential points about neurally mediated, orthostatic hypotension and cardiogenic syncope. If asked, you should be able to tell at least 2 or 3 causes for each of these types of syncope, and you should also know the objective definition of orthostatic hypotension, because examiners tend to be very specific about it. What degree of drop in systolic BP, what degree of drop in diastolic BP, after how many minutes of standing. 3 parameters to be remembered. When you mistake any one of them, the examiners tend to get offended, and in MCQ based question, obviously that means you end up with wrong answer, right? So before we wind up, I have few MCQs to quickly discuss, and then we will connect with the next series. As usual, the Harrison based notes are there in the notes file. So here is one question: which of the following neurological disorder may be associated with orthostatic hypotension? Which of the following hi Utkarsh, hi. Which of the following neurological disorder may be associated with orthostatic hypotension? See, दो ही कंडीशन में ऑर्थोस्टैटिक हाइपोटेंशन हो रहा था, मीन्स डिसीजेस वाइज ड्रग्स तो है, ड्रग इंड्यूस्ड, बट अपार्ट फ्रॉम दैट ऑटोनॉमिक नर्वस सिस्टम डिसफंक्शन, आइदर प्राइमरी वेयर यू हैव degeneration of the neurons in the autonomic nervous system, or secondary, what we call as secondary autonomic neuropathies like diabetic neuropathy or amyloidosis. Okay, Utkarsh Verma, welcome. Okay. So can Alzheimer's disease cause orthostatic hypotension? No. Alzheimer's disease, only the cholinergic neurons in the central nervous system are degenerated. Primary lateral sclerosis is a type of motor neuron disease where only the motor neurons are affected, nothing to do with the autonomic neurons. So the answer here should be multisystem atrophy, which is also called as Shy-Drager syndrome. Shy-Drager syndrome. Okay. And I will tell you one important point about this. See, most of the neurological disorders which are associated with orthostatic hypotension, they are all synucleopathies. Means in these patients there is abnormal accumulation of alpha synuclein in their neurons, and because of this accumulation the neurons start dying, right? Examples are Parkinson disease, Lewy body dementia, pure autonomic failure, and the Shy-Drager syndrome or multisystem atrophy. There is one more finding that binds all these disorders together. All of them are neurodegenerative disorders. All of them are because of accumulation of alpha synuclein. That's why called alpha synucleopathies. Another important binding feature of all of this is REM behavioral disorder. REM behavioral disorder. That is seen in Parkinson disease, Lewy body dementia, as well as multisystem atrophy. So in tomorrow's class, you should tell me what is the meaning of REM behavioral disorder. Okay, interesting topic or interesting concept. So just read through Google and then we will discuss about it. Okay, so I have one more question for you. Which of the following symptom is unlikely to be seen in a patient with syncope? So I have told you, examiner's expectation is you should be able to differentiate syncope and seizure with reasonable confidence. That's what examiners ask you. Which of the following symptom is unlikely to be seen in patients with syncope? Unlikely to be, right? We are asking unlikely to be. And I just told you that myoclonic movements can be seen in patients with syncope, right? We put a table trying to compare between seizures and syncope. So myoclonic movements or jerks can be seen in a patient with syncope. So there are a few points which will help us to differentiate seizures and syncope. Syncope, usually the loss of consciousness is less than 1 minute. Seizures often persist for more than 5 minutes. Second, syncope, the recovery is complete. Patient is not left with any more symptoms after he has regained the consciousness. Seizures, often they have post-ictal confusion and post-ictal weakness or Todd's palsy. Third important point is syncope. These patients can experience urinary incontinence but not the fecal incontinence. Patients with seizures can experience both fecal as well as urinary incontinence. Right, so fecal incontinence is not seen in a patient with the syncope. Right. So guys, that's it from me today. I will add few more questions for you to solve, and in the next session we are going to talk about the chest pain. Again, a very important topic from the perspective of emergency medicine as well as your routine bedside discussion. So we will be taking up about chest pain. It will be helpful if you just read a little bit about ischemic heart disease, right? You might have come across the terms like ST elevation MI, non-ST elevation MI, as well as unstable anginas. Just go through these 3 terms and then we will discuss rest of the things tomorrow. Day after tomorrow. The next session is day after tomorrow and it is on chest pain. Chest pain. Okay. See you all guys soon. Thank you. Thank you everyone. Bye-bye.